about our speakers. We will be recording the video, and I will be able to provide the link to you once it's released after the series is over. This evening, we have two speakers, Dr. Brian Chacon, the medical director of the Adult Down Syndrome Center in Park Ridge, Illinois, near Chicago. Dr. Chacon has provided medical care for adults with intellectual disabilities for over 30 years and has presented and written extensively on caring for adults with Down syndrome. Joining him this evening is Dr. Katie Frank, PhD, an occupational therapist also at the Adult Down Syndrome Center in Park Ridge, Illinois. Most of her work has been with individuals with Down syndrome. And Dr. Frank has lots of experience in treatment and evaluation, as well as facilitating groups for people with Down syndrome and conducting training for families and caregivers. So without much further ado, again, we will mute everybody and turn off all the cameras during the presentation. If you have a question, as you think of the question, please write it into the chat. And after the presentation, Dr. Frank will facilitate the answering of questions that have been put into the chat, but don't hesitate to put it in. It may be covered during the presentation before the Q&A period, but you won't know if you don't ask. So again, we hope to run about an hour for the presentation, followed by a Q&A. And CDSS is very grateful to Dr. Chacon and Dr. Frank for their time this evening in making the presentation. And we hope that everybody enjoys it. So I'm going to pass it over to Dr. Chacon at this point. And again, everybody to please turn off their camera and to turn off their microphone. Thank you. Dr. Chacon.
Great, thank you very much. And you can see that okay, the slides?
Yes.
Great, excellent. Great. Thank you so much for having us this evening. Dr. Frank and I are pleased to be here with you, virtual as it is, but certainly thankful for Zoom and whatnot in this day and age that helps us at least stay somewhat connected. This evening, we're going to talk about what we call the groove in people with Down syndrome. Just a little bit about who we are first. As Laura mentioned, we're from the Adult Down Syndrome Center in Park Ridge, which is a Chicago suburb near O'Hare Airport. And our mission is to enhance the well-being of people with Down syndrome who are age 12 and older by using a team approach to provide comprehensive, holistic, community-based healthcare services. We opened in 1992, and so we'll be celebrating our 30th anniversary in January. And since then, we've seen over 6,000 adolescents and adults with Down syndrome. And we have about 7,000 patient encounters a year. So it's a pretty busy place. Just as a reminder, this information provided for educational purposes only and is not intended to serve as a substitute for medical, psychiatric, mental health, or behavioral evaluation, diagnosis, or treatment by a qualified professional. So certainly you're welcome to share this with your provider, but we're not looking to certainly take their place with this information. So what are we going to try to discuss this evening? We want to talk about the groove. We'll define the groove. We'll outline some advantages and disadvantages of the groove. And there are advantages and disadvantages both. We'll describe problematic grooves, including the diagnosis and treatment of obsessive compulsive disorder. And then we'll share some strategies to address problematic grooves and establish new grooves, some very practical suggestions that Dr. Frank will be sharing with you shortly. So let's start with what is the groove? So really the groove is a set pattern or routine in one's actions or thoughts. It's also a preference for sameness, repetition, or routine. So the groove is not unique to people with Down syndrome. Certainly we all have grooves. They help us to do automatic tasks in our day. We need them to complete, helps us to complete routines. And certainly people with Down syndrome particularly will use the groove to complete the entire routine, which is a very common observation. We call it the groove because people's behavior tends to follow fairly well-worn paths or grooves. And again, this is really something that can be seen at all ages in people with Down syndrome, from quite young to certainly some of our older individuals. and certainly in some of our older individuals, actually, like many of us as we get older, we get more groovy, if you will, and tend to be a little more stuck in our routines as we get older. And that's not unusual for people with Down syndrome either, as it is for all of us. So what are some of the advantages of the groove? So really, it gives order and structure in daily life. It can help increase independence. It can enhance performance and function, and it can help people manage stress. So I like to think that this groove, this tendency towards groove that people with Down syndrome have, really in a lot of ways helps many of our the people we see, our patients, to actually function in a sense at a higher level than you might think they could from their cognitive level or their cognitive skills. So that this ability to do things the same and repetitiously really does help them function well and be able to do things that you might think they may not be able to do otherwise. So just an example, we have a patient who wraps silverware at a restaurant. She very much likes the repetition. She doesn't get bored, and she does a great job. And it's a job sometimes that others don't want to do. So it makes her excuse me, COVID negative. I tested this morning. It's a job that maybe others don't like to do, and she's very good at it, enjoys it, gets a lot of satisfaction from it, and does an excellent job in it, and is a very valued employee. So what are some examples of grooves? So a groove, it can be using a precise and unchanging routine to complete a task. For example, many of our patients have very meticulous care of their room and personal items, and everything has its place. I remember years ago, I went to meet actually an 83-year-old woman with Down syndrome, who was the oldest person that we have seen. And I went to meet her and where she lived, and she had about 35 stuffed animals on her bed, and I picked one up just to sort of have a conversation about it and set it back down, and set it about an inch off from where it had been when I picked it up. And she immediately walked over. The conversation stopped. She immediately walked over, put it back, moved it the inch to where it belonged, stepped back, and then the conversation resumed. So that's not an uncommon. Everything really has very meticulous place that it belongs. We see folks that will close doors and blinds and turn lights off. That certainly can be a good thing. When you're leaving a room, turning the light off. On the other hand, sometimes if it's closing the doors when people don't want them closed, that can be a challenge. It might be repeating familiar phrases, or it might be listening to the same music, watching the same TV show or movie over and over, which again can be very comforting for the individual, but for those around, can get a little sick of watching the same video or hearing the same song over and over and over. You can probably think of examples in your own lives of individuals with Down syndrome that have a groove, or even of your own. I mean, I put my keys in the same place theoretically every night when I come home, so that in the morning I know where they are and I can get out the door more quickly. And so we all have things that we do like that to help us function. You can think where there's a positive aspect to the groove in the person with Down syndrome in your life, but you could probably also think of examples where this could become excessive and problematic. And again, some of these are habits that we all have, and they really don't make a difference. I mean, they just are, and they're certainly not necessarily a problem, and maybe not a big advantage, but they just are. Sometimes they do not have all have a function, and sometimes they're not all obsessive compulsive. So they're just sort of habitual things that people do. Some of it's personal preference or societal norms. So there's a lot of reasons that people will have grooves, and again, it's neither nor it's not all good, it's not all bad, and there are some good aspects and some negative aspects, and we'll go into more detail. So what are some of those possible disadvantages? So certainly, if there's a great deal of inflexibility where the person really is not able to deviate from the groove at any time, sometimes it makes transitions difficult, where the person really has a need to complete a task all the way through, And if you interrupt that task sort of mid-task, that can be difficult for the person to transition to the next thing. It can be difficult with disruptions if the person's in the middle of something and there's an interruption. That can cause some challenges at times. And sometimes it's difficult to generalize. There's difficulty generalizing skills and knowledge to other settings. So good. Most of the time, the groove is good until until it is not. And again, the difficulty with transitions, taking that task all the way through can be a problem sometimes if that gets interrupted. Difficulty generalizing. This is tied in with cognitive abilities and concrete thinking. So a lot of individuals with Down syndrome, based on their cognitive level and their tendency more towards concrete thinking rather than more abstract thinking, they might have difficulty generalizing it to another setting. So not able to generalize the groove across multiple settings or situations, and that sometimes can be a challenge as well. So what are some problematic grooves? So, this can be we know that this groove seems to be a real coping mechanism and something that can be very helpful. But sometimes it can go kind of awry. In some environments, there's a lack of appreciation that the groove exists. And so if you don't acknowledge that the individual has this tendency towards the groove, and we give them a job where we're really sort of fighting their groove, we're likely to have some headbutting or some challenges in that situation. Sometimes that happens again where we ask them to do a task that is not really capable of being completed in the time frame that we have, and with the intention that we'll pick it up later. And if the person does have this tendency towards really wanting to complete that task all the way through, that can be a challenge. We certainly know that COVID has been one of the big problems with COVID from a standpoint, obviously, of the infection, but from a standpoint of mental health. It's prevented people from doing many of their grooves. And so that has been a real challenge. Some have lost some of those grooves because they're not able to, in a sense, practice them. Some have fortunately picked up some new grooves, and some people have turned that into a real plus, and it's been a real healthy thing. Excuse me. And again, sometimes as I mentioned before, sometimes as people age, the groove can become more or less rigid based on the development of either aging or even the onset of Alzheimer's disease. So some of the problematic groove issues, the grooves can become less functional over time. And again, the grooves can become more or less rigid. And some of the causes for this can become stress, due to stress, pain or physical ailment, mental illness, dementia, communication issues, sensory issues, and certainly environmental issues as well. For all these reasons, the groove may change and become less functional, more rigid, less rigid, whatever. And so those are, when we do see it, again, we don't see the groove in and of itself as bad, but if we see a concerning change, we want to go looking for some of these underlying potential causes. So how do we manage the groove? Well, first off, one of the questions is, when should the groove be challenged? So certainly when it impacts safety, when it impacts function, when it impacts the family. Periodically, you might want to think about challenging the groove just to promote some flexibility. And then in certain environments where the groove is not functional. So for example, Dr. Frank likes to use the example of in certain environments, such as someone sits in the usual spot on the bus, and they get on the bus and someone's sitting in their spot. It's not likely that it's going to be real functional to go up to a stranger and say, get out of my seat, or something along those lines. So that, there's certainly in some environments, in some situations, that is not going to be an acceptable thing. And so we need to learn how to be flexible in that situation. Certainly in some situations, it can impact the family, and not be a problem for the individual with Down syndrome themselves, but can impact the family, and certain families going to have to work through that and how much of the groove needs to be changed versus how much do we need to just accept the groove. And then, excuse me. Then we want to look at priorities. Is this groove, how much of a problem is this, and how much does it challenge other things that the person is trying to do or prevent the person from doing? And so that was, again, trying to decide, sort of which battles we're going to fight, if you will. And then a lot of times the groove doesn't need to be challenged all the time. I mean, there may be times where just, that it's okay. I mean, it's not a problem. It's not really harming anything, and we'll just let it be. And so those are a lot of things we're trying to decide as you look at and how the groove is impacting the person's life and also the life of the family and those around them. So again, I like to use the term, most of the groove is good. And most of the time the groove is good until it's not. And so it can be very functional, as way over on the left there. At times it can become less functional and even sometimes not functional. And then certainly this tendency towards repetition or sameness really can take on the air of obsessive compulsive disorder, where the person's really stuck in a rut, if you will, where they're really, it's no longer, it has become functional. It can become an impediment to life, where someone can't move on to a new task, can't get to their job, they may lose their job because they're so doing something repetitively in the morning. It can cause people to be late for things. It can cause family members to not be able to do what they need to do through the course of the day because the person with Down syndrome is really stuck on doing something over and over and over. Years ago, we had a gentleman that really liked to clean. He was excellent at cleaning. He lived in a residential facility where his house was just spotless because he was such a good cleaner, and everyone appreciated that. But it began to become problematic when the overnight staff, one of their jobs was to clean, and our gentleman with Down syndrome started to stay up all night and sort of supervise or monitor the staff to make sure they were cleaning up to his specifications. And that obviously became a problem. He wasn't sleeping. It affected his physical health. And then also he wasn't able to then function well the next day in his job. And so he was beginning to lose that opportunity as well. So again, that would certainly be a groove that became very functional, and ultimately he ultimately developed obsessive compulsive disorder that needed to be treated. We've had individuals that worked at a restaurant, and one of their jobs was cleaning the restroom, but they were so meticulous and so did such a good job of cleaning the restroom, which was a very functional thing. But at some point, they would become so involved in cleaning and wanting to make sure that it was so perfect that no one could use the restroom in the restaurant, and that obviously was a problem and had to be addressed. We've had individuals that were where their job was to bus tables, and they like to do it in a very specific order. That was their groove. And so they might be bussing tables 1, 2, 3, and 4, for example. But it had to be 1, 2, 3, and 4. So if table 3 finished before table 2, the person went from table 1 to table 2 because he had to get to table 3. And so the people at table 2 who weren't finished with their meal, were being hustled along, and their food and plates were being taken away because he had to get to table 3. So obviously that was not a functional groove at some point. Again, excellent at busing, but then there was this additional problem that had to be addressed. So certainly that, those are things that have to be addressed, and Dr. Frank's going to talk about that in a second here. Sometimes the issue is along the continuum, or it helps determine where you are along the continuum, is how much does it impact the lives of others. Again, if the person is able to do the groove and do their own tasks and get to other things, and it doesn't impede the flow of the family, it can be quite functional. But if it again becomes more repetitious and the person is not able to move along, and so the family is missing out on activities or not getting to places or whatever the case may be, again, that becomes more problematic and will have to be addressed. So I am going to stop and turn it over to Dr. Frank, and she's going to address some of those strategies on how to address these grooves.
Wonderful. Thank you, Dr. Chicoine. And you'll find that many of the grooves that Dr. Chicoine mentioned, I will be repeating, but talking about how we can use certain strategies to address those grooves. And as an OT, I don't really always look at what we're talking about as the groove, because I see my job is to help people function well. And so oftentimes we use the strategies that I'm going to discuss to help them function well. But it's also great because these strategies can be used to challenge the groove at the same time. Next slide. So the first strategy would be to educate others. And sometimes it's because you don't need to challenge the groove. It isn't about changing the person, but really changing the environment. And so we need to educate others. We have a friend who, before COVID, was working in a cafeteria at a local college, and his job was to clean the tables during lunch. Now, he didn't have the groove that he needed to, wipe down table 1, 2, 3, and 4, but he had trouble wiping down the table before the next set of students came to sit in those seats, and he became frustrated and had trouble managing his emotions, and it ended up impacting his ability to do his job successfully and feel good about himself. So we talked with mom and with staff, and we ended up suggesting perhaps he clean the tables before the lunch periods and after the lunch periods, but perhaps during lunch he could help do the dishes back in the with the dishwasher. And that seemed to work for him. So he was still feeling very positive about his work experience. He was successful and he was still able to do the job, but we modified the environment just a little bit, not him. We also know that individuals with Down syndrome may just do the job differently than we believe it should happen, but perhaps they're just as efficient in completing the task in that way. And so is there really any need to change it? Or we know that individuals with Down syndrome like to complete jobs without interruption. We have another friend, Jay, who works in a lab, and his job is to empty the dishwashers at each lab station. Well, the other employees at this lab tend to want to empty their dishwasher on their own schedule, not on Jay's schedule. So we just did a little bit of education and said, Jay really likes emptying the dishwashers. He knows how to do it. He's successful. Will you just please leave your clean dishwasher full when he comes around? Just let him interrupt whatever you're doing to empty the dishwasher so he can move on. It doesn't really impact their day. If they needed to get, a utensil out of the dishwasher for their lab work, they could. But it just kept everyone happy. And so it's just important to educate all of those around the person with Down syndrome. And it may be the boss or fellow employees. It could be to teachers and support staff, but it could also be other family members. And sometimes it may even be reminding yourself that this is something they need to do in order to get through the task. So maybe they have to push the chair in and pull it out 3 times before they sit down at the table. Is that really that big of a deal? If we just let them do that and sit down, it doesn't take much time, and then everyone can remain happy. Because if the groove isn't impacting their safety or function, perhaps we just need to adjust our behaviors around the groove. Next slide. Another strategy is to encourage flexibility. And you heard Dr. Chicoine talk about this. And in the mental wellness book, it's referred to as the F word. And it's really because individuals with Down syndrome don't like the word flexibility. So there's a few strategies to incorporate in order to encourage flexibility. And the first one is to pick a behavior that is possible to change. And so you can ask yourself the question, is this just a nuisance to the family, or is it really a behavior that impacts their safety? So if you think it's something that might impact their safety, then we would want to address it. It's also important to pick a time to encourage this flexibility. So perhaps pick a time of day when there isn't urgency to complete the task. And I also like to say that, parents, you're the parent, you are not the therapist, and it's not your responsibility to act like a therapist 100% of the time. So this way you can still be their parent and kind of incorporate these therapy strategies for a short amount of time during the day. And so this might not be a groove per se, but oftentimes with dressing, I often suggest working on it over the weekend since there isn't pressure to get out the door in the morning. Or perhaps at bedtime, you work on undressing and then getting on the pajamas, because that just is less of a time constraint than in the morning when they have to get out the door for school or work. We also want to provide alternative behaviors that are more appropriate. And this is where you can offer choices. If the morning routine takes too long, Perhaps you suggest selecting the clothes for the next day as part of the evening routine the night before, or even packing the lunch the night before so that it's already ready in the morning and easier to get out the door. It's also important that when teaching a new behavior, to break the task down into manageable steps. And occupational therapists call this activity analysis. And everything seems just a little bit more manageable when we break tasks down into these smaller steps. We can use this to teach the behavior or even practice the behavior, right? When we know that we break things down into steps, we can just work on step 1 and 2, and then 1, 2, and 3. This also helps us tell where the challenge is in completing the task because they get stuck on one of those steps. You're going to hear me talk about visual supports a lot today, but this can help to encourage flexibility because visual supports help manage expectations and set limits. They can help increase or maintain independence. And in the case of flexibility, we can be used to offer choices. So do you want to do this task first or this task? Or today is a shower day. Do you want to shower this morning or this evening? We also want to make sure all participants are open to the change and not stressed during the teaching. And this is both for the caregiver as well as the person with Down syndrome. And then finally, it's important to build the term flexible into exchanges and point out when others are not being flexible. You know, we talk about this a lot. They aren't learning about flexibility because they have Down syndrome. This is something that everyone needs to have. And so it's important to encourage that with them, as well as just using the word flexible more often in conversation. Next slide. So another strategy is to set expectations, and we can do that by giving choices. So perhaps limiting the number of options or offering a choice for an activity will be done. And this is good to help challenge the groove, especially when one of the options may not be a preferred activity, and it can also help change the groove. We can also set guidelines for the individual. So perhaps they like to color. So you get to color for an hour. That's the preferred activity. And then you come out and spend time with the family. That would be their less preferred activity. Or you color for an hour and then you come and eat dinner with the family. And like I said, you're going to hear me talk about visuals a ton. And again, one of those purposes of visual supports is to set expectations. So it can be a first then board or a daily schedule or a to-do list. And here are some examples. So you can see there's a visual with the 3 green boxes. And imagine there's Velcro in those boxes. And then there's 6 activities below. So this was actually created for someone who came home from work and then didn't know what to do. So those are all preferred activities, and he had to select 3. But this would be a great way to work on challenging the groove, because one of those options might be one of the less preferred tasks, or that change in the groove, where you say, we're going to do this, then this, then this. And there aren't options for them to choose which 3 they do. And you can use that 1, 2, 3 board. You can also see at the bottom, there is a shower schedule. So this visual helps someone know exactly what step, it's that activity analysis of the shower and what step comes next. So that can help set expectations so that they know, all right, after I wash my face, I need to, wash my arms and my chest or whatever it might be. And then the one on the far right is looks like a morning routine. So I wake up and I use the restroom and I do all these things. And again, this can help set expectations so we can get them out the door faster. They know what comes next. We can also set time limits, and there's a variety of timers, whether it's this time timer that there's a picture of, using a countdown on your phone or on a watch, on your stove or oven, whatever it might be. We can use these timers. So someone who showers too long, you may not even have to set a timer, especially if they don't like the sound of the timer, but you have a shower playlist. So you have the 2 songs, 2 of their preferred songs, and they know that when the song's over, they have to end their shower because they usually waste all the hot water. Or you can have them listen to their music to make the shower more appealing for them, but then you you chime in words through the playlist where you're reminding them, okay, now it's time to wash your hair. Now it's time to turn off the water. And again, they can listen to that, make it a more preferred activity, but we're setting expectations. We also hear that sometimes, individuals don't like to use visuals. They feel like they're childish. Well, I always tell people they're not childish. We have grocery lists. We all have smartphones, and we know the app based on the picture, not on the words. So visuals grow and change with us. So I suggest trying them every so often, but knowing that there's different kind of visuals. I mean, you can use the pictures of the real item instead of these cartoon pictures, or you actually use the real item instead of a photo. Or if they can read, you use words, right? And it's important to encourage the individual to create the visual with you, and then they take some ownership into it. And I'm often asked how I make my visual supports. So I use a program called Boardmaker. It is a paid service. It's a web app that anyone can sign up for, but there's also some free websites of pre-made visuals. You can always use Google Images, or like I said, you can use just pictures on your phone or the real items. And all of those are different types of visuals. Next slide. So one of the things we do here so often is practice social skills. And these social skills really help individuals with Down syndrome be successful whenever they're out in the community. So trying to role play possible scenarios can help. And these are some of the topics that we really try to focus on, because they're hard for many people. But it's something that many of us kind of take for granted and just know we're supposed to do this. But individuals with Down syndrome really need to learn these skills, because many of them are fairly abstract and not so concrete. So compromise is one of the first topics, and it's important to understand that and knowing how to suggest a compromise, especially if being told no. So here's an example of a handout we have on compromise, where these two individuals wanted to do two different things. So we talk about 3 different ways you can compromise. The first is you select one item from each person, so they each get a little bit of their way. The second option would be they do one person's ideas the one time, and then the next time they do the other person's. Or the third way to compromise is no one gets their way, and they come up together with an activity to do, and they agree on it. So someone today, even in social skills group, told us that to them, compromise means everyone agrees. We also know that being told no is hard, and individuals with Down syndrome don't get to hear that very often and don't really know how to respond. So we talk about how we can compromise if we're told no, but also they need to learn that being told no does not mean that they're in trouble or that they did something wrong, right? And so giving them a skill to handle being told no. And this also goes along with flexible thinking. With compromise and being told no, is that we shouldn't always act like a rock. And sometimes we kind of need to be flexible like a yoga pose. And this is something we need to teach in order to manage those problematic grooves. It's also important for them to understand that it is okay to ask for help, because sometimes they may fear that if they're asking for help, that they aren't being independent. And we've worked so hard on, teaching them and helping them be as independent as possible. So we can talk to them about how everyone asks for help at some time, and perhaps we even demonstrate asking them to help us with something. And we know that when grooves become problematic, oftentimes if we get interrupted or we can't follow through with our groove, we may act out. So we need to practice managing our emotions. And again, if we haven't educated others on the groove, we might see more of these negative behaviors. And so we need to identify positive strategies to manage their emotions. And we often teach that it is okay to have negative emotions. Like, it's okay to be mad, but when you're mad, it is not okay to hit or bite or, slap or use mean words. And so, we have a handout there on some just easy strategies you can do without any equipment in order to calm down so that you can manage your emotions appropriately. And then it's always important to have socially appropriate behavior and good manners. So for that instance that Dr. Chicoine was talking about with, someone is sitting in your seat at the bus, it would not be appropriate to walk up to them and just sit on their lap. or to walk up to them and tell them they must move because they're in your seat, right? So these are all different social skills that should be practiced and learned, and role play is a great way to teach that. Next slide. So then the last strategy really is implementation and what that might look like. So the first thing that helps with implementation is to prepare the body, because it can really set the stage in order to help challenge the groove. And we do this through sensory input. So again, if you've ever heard me talk, I usually talk about sensory and visual supports. So with sensory, I'd like to start with proprioceptive input. And this is the input into our muscles and joints. And it helps us be aware of our body and where our body is in space. And so we naturally get proprioceptive input with any activity that has like a pushing or pulling motion. So chores are a great way to get this, but we can also use joint compression, which is the handout you see there. But I like to describe the body throughout the day is often like a teeter-totter, where we have our highs and our lows. But in order to be able to tolerate change in routine and transition, we need our teeter-totter to be even and not moving up and down. And so sensory input can help even out our teeter-totter so that we can better handle change and transitions better, and therefore, as a caregiver, be able to challenge the groove if the person with Down syndrome's teeter-totter is even. It's also important that we pair the problematic groove with another desired activity. This helps with implementation. So this is a great opportunity again for that first then. Perhaps first we make the bed and then we eat breakfast, hoping that the motivation to eat may speed up the lengthy process of making the bed. Or like I said before, first we color for an hour and then we come hang out with the family. It's also important to pair changes together. And again, this isn't with the groove, but it sort of is like with the groove, because oftentimes individuals with Down syndrome end up getting orthotics. And so families put their new orthotics in their current gym shoes, and then they don't like to wear their shoes anymore. So we often suggest to pair the new orthotic in a brand new pair of shoes. And so the same thing happens with the groove. So we can pair the changes together, whether it's a change in the living environment or a motivating date like their birthday or the new year. Just recently, I had a family and their son, who was a young adult, was sleeping in the living room and not in his bedroom. But over the summer, he went away to summer camp for 6 weeks. And when he returned, the mom just said, you know what? You don't sleep in the living room anymore. You're sleeping in your bedroom. And sure enough, it worked. Now, it doesn't always happen that fast, but for him, he'd been away long enough and had been out of his groove for long enough that when he came home, it was easy to just have him transition up into this bedroom. Like I said, that was over the summer, but I saw him just a couple of weeks ago and he's still sleeping in his bedroom to this day. So that was a great way to challenge the groove, interrupt it, and teach that new groove. Next slide. So we've talked about some strategies, but now we're going to go over some common groove scenarios and how to incorporate these strategies. So next slide. We often hear that routines can be lengthy. So whether it's the morning routine takes a really long time or the bedroom routine, we can do things like give choices and set guidelines and time limits and use visual supports. We talk about making the bed a lot, but it's because this is something we hear. So one of the things we can do is perhaps limit the number of pillows or stuffed animals, right? So they have fewer things they need to put in the exact location. Or even moving it to a different part of the day. All right, so they still want to make the bed, but it takes too long in the morning. Let's just move it to when they get home from school or work. So it's still made when they have to go to bed, but it's not interfering with their morning routine. We've talked about taking a long shower at bedtime. So again, setting time limits, whether it's the timer or with their playlist, you can use that visual support, first shower, then snack, or whatever that might be. And just getting ready in general. So using that visual support for the routine, like we saw earlier with the morning routine, setting a timer so that they know when the timer goes off, they go to the next step of the routine, laying out clothing the night before, or offering choices between this outfit or this outfit, even limiting the number of options in the closet that they can choose from. Perhaps they bring a backpack with lots of belongings with them everywhere they go, right? So in the morning, they have to pack it. Also, we can have them keep a list of what they can bring with them. Maybe they usually put in 20 markers, 8 magazines, and 2 notebooks. Well, we might make a list and say you can bring 2 markers, 2 magazines, and 1 notebook. Or we can have the visual. So maybe it's a poster board that lays out that has the picture of what they can bring and how many, and then they have to match it up before they put it in their backpack. And then overall slowness can really be challenging. And so this would be a great opportunity to use that proprioceptive input or sensory input to kind of set the body and prepare them so that if their body feels regulated, their teeter-totter is even, they're going to be more open to moving just a little bit faster. And then we can implement a visual support to assist with that. Next slide. Dr. Chicoine talked about how it can be difficult to generalize skills across different environments. However, this really could be beneficial with the groove when you think about it, if they can have different routines in different environments that may actually be more appropriate. So maybe someone's chore at home is to clean the bathroom and their job at work is to clean the restroom. But at home, they can clean it whenever they want. And that doesn't impact anyone because it's just them and their parents and they have their own bathroom. But that groove wouldn't work in their job because they can't just clean it whenever, because it impacts their ability to complete the rest of their job, or perhaps someone's in the restroom and they're not supposed to clean the bathroom when a patron is using it. So this is a great opportunity to be like, well, we've got a groove in each environment. We don't want to generalize the skills. And so these separate grooves are truly beneficial. But oftentimes there's also different routines on vacation or at your house versus where their group home or their apartment is, or mom's house versus dad's house or sibling's house or grandparents' house. And so it's important to try to incorporate the desired routine, but also it's a really good opportunity to work on flexibility in the groove in these different environments. And it's a great opportunity to set guidelines. And again, we can use the visual supports to help establish that new groove. And in general, pairing the changes together can really help establish more functional grooves and eliminate the problematic grooves. And so we've definitely seen a move to a new home. So you're moving from one family home to a new family home, and they've been, when they always come home from their apartment, they have to shower the first thing they do when they walk in the house. And it doesn't matter if it's morning, evening, whatever it might be. But now you have this new family home. And so you can get rid of that shower the first time they move in because it's a whole new environment. And so we just teach, this is what we do here. And we can use that visual, and we're pairing the changes together. And we saw a lot of this during COVID. And so now is a great time to challenge those routines that were established while home, because we have more opportunities now to leave and to go see people and places to go. So we can take that opportunity to challenge the groove just a little bit so that we can get out the door a little faster. Next slide. So we know there's at least 2 different ways that individuals with Down syndrome have difficulty completing their job tasks, whether they need to complete tasks in a certain order, or when they're interrupted, it can impact them and they have to start from the beginning. So we have some examples. Sue is really great at her job because she knows that when she's at work, she wipes the menus, then rolls the silverware, and then cleans the restroom. However, one day she goes to clean the restroom and there's a patron in there, and she knows the rule that when a patron's in there, she's not supposed to clean the restroom. However, she knows that she already rolled the silverware and she must clean the restroom. So she just knocks on the door continuously and tells them they have to come out so she can clean the bathroom. And she knocks until they finally open the door. Well, if any of us were to do that at work, we might get reprimanded. We could get fired, right? But we don't want this for Sue. So this would be a great opportunity to educate. We could talk to the supervisor about the groove and perhaps rearrange the order of jobs so that the bathroom is clean before the restaurant gets open. So maybe she cleans the bathroom, then wipes down the menus, and then rolls the silverware. We can also use this opportunity to practice social skills and to role play scenarios with Sue about what to do when the bathroom door is locked. And we can set rules and guidelines and say, when the bathroom door is locked, ask the supervisor for help. Because oftentimes, if we tell someone with Down syndrome what to do, they respond better than saying, don't do this, because then they don't know what it is that they're expected to do. So we should always tell them what we expect from them. And then as far as getting interrupted, Chris's responsibility at work is to bring the carts in from the parking lot. And he's very methodical in selecting the carts to bring in. But the problem is one day there just aren't any carts left inside the store. So his supervisor comes out to help take the carts in, which interrupts Chris's groove, and he gets very frustrated and yells at his supervisor. Right? Again, this is not a situation we would want for our loved one with Down syndrome. And it's something that if we were to do it, again, we'd get reprimanded or fired. So we could talk with Chris's boss about the groove and maybe why he acted the way he did. And we can use visuals with Chris to help him know when to bring in the carts. Or perhaps we give him the guideline that he checks each parking lane and maybe brings in one parking lane at a time, or he brings in 5 carts. So once he has 5 carts, then he can bring them in and then he can go back out and get 5 more carts. And then it will also be important here to practice strategies to manage emotions for when he gets upset, because we wouldn't want him to lose his job. So we could role play with him and give him strategies, even telling him to, when he starts to feel like his volcano is going to explode, he stops and takes a few deep breaths before he acts. All right, next slide. So you've already heard us talking about sitting in the same spot a lot, but again, it is something we see. So whether it's the same spot on the train or bus, or at their activity, or they always want to be in the front seat of the car, we just need to know, how to help them through this. Because again, we don't want them to just go sit on someone's lap or tell them to move, or even worse, what if they went to get on the bus or train, someone was in their seat, and so they just got off the transportation to wait for the next one and they were late for work, right? So whatever it might be, we really need to build in flexibility and work on taking turns. So we give them options. Maybe they get their seat 2 days a week and you select those days, and they have to sit somewhere else on the other days. Or you could create a visual support to reflect this new schedule. Or with the example on the bus or the train, we can tell them, they have, maybe 3 different seats that they could choose from, and just hope that someone's not always in that seat, one of the other seats if someone's in their first seat. And then, we have here, before COVID, we had Zumba in person, and everyone had their spot that they like to stand. And if someone missed a week and a new person came, they just naturally took that spot. So imagine, week 3, and both people are there fighting over that spot, and they are trying to do their Zumba right on top of each other. So we can give them another task. Maybe we have one person say, hey, would you stand by the music today and help me turn on and off the music in between songs? Or you can incorporate dance moves that get people to move around so that they don't always stand in the same spot. You can have them get in circles or whatever. You can also establish lines or boxes on the floor for people to stand. And you just make sure that each week everyone changes. It's kind of like musical chairs. And then it's important to practice taking turns and compromise, and even ask for help if they see someone in their seat or they want to sit or stand there. So maybe if they get on that bus and someone's in their seat, they know to ask the bus driver, can you tell me, is there another seat I can sit in? And then just wait and be told where else they can sit. Next slide. Wearing the same outfit. So, if you don't want to change the groove when it comes to this, that's fine. I challenge you to do laundry every night, which you might already be doing, or even having multiple sets of that exact same outfit. But if you do not want to do that, you could change the groove. So some options would be to limit the clothing in the closet and give them choices, but it also encourages flexibility, right? So that outfit's just not there. So do you want this one or this one? Maybe you establish their clothes for home and clothes for community. So that outfit they want to wear time and time again might be their home clothes. But when they have to go out in the community, they have a different outfit. Or maybe they have clothes for the week versus the weekend. Maybe you establish days of the week that they can wear that outfit and that they need to select a new outfit on the other days. You can use a visual story to explain that clothes need to be clean every day. And if we're dirty or wear dirty clothes, that no one wants to be around us. Or we have a calendar on a day where they can wear their preferred outfit so that they can see it. Maybe they even pick the day. We also see that some people talk about that same topic or the same person continuously. And many of these same strategies can help with that. Setting guidelines about when they can talk about the topic, or maybe who they can talk about the topic with, or where they can talk about the topic. Perhaps giving them the choice when the person wants to talk about the topic. You can have them set the timer. Perhaps if they start talking about something, you direct them to write in a journal, and they can write their thoughts down. Or totally redirect them, like saying, it sounds like, and then offer an alternative topic that perhaps you would want to talk about. Next slide. So for many grooves, individuals with Down syndrome really tend to get stuck. And so these strategies can help someone get unstuck. Again, with that person that repeats the same words or phrases all of the time. We want to make a less functional groove just a little bit more functional, perhaps instead of stopping it altogether. So you can use a visual that they can refer to that answers the question for them. So if they ask, what's for dinner every day? Perhaps you have a picture that shows them what's for dinner and you just say, what does your picture say? Or they write it down. What did you write down? What did you say we were having for dinner? Things like that. Because again, it's frustrating for us when they constantly ask that same question, but we want to help facilitate a change instead of just get frustrated with them. Again, it's wonderful that someone wants to make their bed every morning, but again, to lessen the time, we remove the pillows or the stuffed animals that impact their ability to complete the task in that short amount of time, and allows them to make their bed, again, maybe even later in the day, so it just doesn't impact their schedule at all. And really helping get unstuck is just one aspect of the groove that helps encourage a little bit more functionality. Next slide. So then how do we establish a new groove? We really do need to get someone unstuck first in order to establish that more productive groove. And so, we do things like setting guidelines and using the visuals, but really pairing with another change, like we talked about before, is a great option. So the new environment, or an important holiday, school recently started back up, or where people are starting to get back to work. So that's a good time to establish a new groove. We're getting into the holidays, and that can be challenging, but we have the new year. So we can say, oh, maybe in the new year, you'll do X, Y, and Z. And so then we're starting to prepare them for that change and challenge in the groove once the new year comes. And it's important to build in flexibility and have that schedule and show them how we're trying to establish this new groove. We also can pick a more convenient time for the groove. Again, like the cleaning the bathroom scenario. We ask them to do it in the afternoon instead of in the morning when everyone else in the family has to use that bathroom to get ready for school and work. We also know that trying to move someone with Down syndrome along just a little bit at a faster pace is going to result in them slowing down further, and it might even cause them to shut down completely. So we can use pictures or set guidelines, not necessarily to speed them up, but to help them organize their thoughts and be more functional with the groove. And we can also, if we have to, especially if we need them to move a little bit faster, again, use that sensory input, that proprioceptive input, to help reset their body, even out their teeter-totter, so that they're prepared for that change and can move just a tad faster. Next slide. So in summary, general strategies that can be used for problematic grooves and establish new grooves, or even help with obsessive compulsive behaviors in combination with medicine, really are the things we talked about today. We want to educate others about the groove. We want to encourage and build in flexibility, set expectations, practice social skills, and really work on implementation and execution. So with that being said, I'm passing it back to Dr. Chicoine, and he is going to wrap up.
Thank you, Dr. Frank. So certainly there are times when the groove, if you will, becomes very problematic and really does meet the criteria of obsessive compulsive disorder. And so we want to talk a little bit about that as well. So, you know, there may be some very repetitive behaviors, some very persistent thoughts. It can impair function, and it really can limit opportunities. And it is often associated with anxiety. I like to say that it's typically not an accident that the chapters on anxiety and obsessive compulsive disorder are often right next to each other. There really is a real interrelationship there. You know, it's interesting that in people without Down syndrome, a common compulsive behavior is hand washing, and we have seen it, but we don't commonly see that. It's not a common thing that we see in people with Down syndrome. But it's interesting in people without Down syndrome, they're typically upset by this drive. They don't want to have to wash their hands over and over and over, and that it upsets them that they feel this compulsion to do so. It's interesting that for most of the people we see and have diagnosed with obsessive compulsive disorder, they don't seem upset by what they're doing repetitively. They like to watch that movie 40 times. They like to, rearrange the pillows in their bedroom, even though it makes them late for work. You know, there is not typically that same getting upset by being compelled to do those things by their obsessive compulsive disorder. When people with Down syndrome typically will get upset actually is when someone gets in the way of their groove or their compulsive behavior. And so if you, what I say, block that behavior, then they will become anxious and sometimes will get upset and agitated even. So really the problem becomes more, so again, not so much that people with Down syndrome, it happens, but not as much where they get upset by what they're doing. They get more upset if you prevent them from doing it. And that would be more typical of what we see. So really the problem with people with Down syndrome is, those two things. One is where they get upset if we block the behavior. And the second is if it is preventing them from participating in something else or getting to school or work or whatever the case may be, because they're so focused on that one thing. So we talked about a number of previously mentioned causes for changes in the groove, and so that I won't repeat those here. The other thing is that there definitely with obsessive compulsive disorder, there is likely an imbalance of neurotransmitters or chemicals in the brain that do contribute to this. And we do know that some of those chemicals do seem to have different levels in people with Down syndrome than in others. So certainly we want to focus initially on non-medicinal strategies, and that we've gone through those, Dr. Frank went through those extensively, so I won't repeat all that. But all those things that we talk about with helping with grooves can also help with obsessive compulsive disorder. The difference is that with obsessive compulsive disorder, often this compulsiveness is so strong that those non-medicinal strategies may not work without some medication assistance. So in that situation, then we would start the medication and then really then go back and look at using those non-medicinal strategies again. It's not that those strategies are not functional in this individual, it's that this drive is so strong that those strategies don't work until we soften that a little bit. And so in a lot of ways, I look at the medication as the softening this compulsive behavior enough that the person can then respond to the non-medicinal strategies. So really, using them in tandem is typically what we would recommend. Just as general rules of thumb for treating people with Down syndrome for mental health issues, we like to say start low and go slow, meaning we usually will start at a low dose of the medication and slowly go up as needed based on response. Going too high too fast can cause significant side effects and may actually then make the medication unpalatable, and then we lose out on that medication. Where if we'd gone slower, started lower and gone slower, we may have been successful. Some individuals may need more than one medication. And then I want to just talk a little bit about what some of those medications are. So certainly the typical, the most commonly used medication would be what are the antidepressants. Not that the person is depressed, but these medications also benefit obsessive compulsive disorder. And a common category would be the selective serotonin reuptake inhibitors, or the SSRIs. And then also there's sort of the cousin of the SSRIs are the serotonin norepinephrine reuptake inhibitors, the SNRIs. Sometimes benzodiazepines, medication like diazepam or lorazepam or alprazolam, the diazepam, also known as Valium. So that category of medications can be of some benefit. And typically, we would use those in conjunction with the antidepressant, not in and of itself. And then sometimes if there's a significant agitation issue with it, if when the person gets blocked, if you will, from doing the activity, if they become very agitated, sometimes we'll use a mood stabilizer as well, typically along with the antidepressant. And we might use an anti-epileptic or anti-seizure medication, something like valproic acid, which can be helpful, or sometimes the antipsychotic medications, particularly the atypicals, the newer ones, things like risperidone, aripiprazole, and some of the other newer medications. Again, that's certainly not a place to start typically, but based on the level of challenge that people are having with the obsessive compulsive disorder and what some of the other symptoms are, some of those medications may be indicated. So what are some of the takeaway points? Just in general. So the groove is a preference for sameness or routine. There is a continuum from where a groove is very functional or most functional to when it becomes obsessive compulsive disorder. When it's functional, it can help increase independence with a variety of tasks. It can actually be a very, very beneficial thing to do, or skill to have, if you will. When it becomes less functional, or it is less functional, it can lead to a lack of flexibility and difficulty with transitions or unexpected changes. As Dr. Frank has discussed extensively, there are a variety of non-medicinal strategies that can be used to help a less functional groove get unstuck or establish a new, more functional groove. And if obsessive compulsive disorder is diagnosed, it is possible non-medicinal strategies will be most effective if also paired with a medication. We have on our in our online resource library, we have a number of resources. We have an article on the groove. We have some mental health resources, also some sensory resources, which Dr. Frank talked a little bit about, and also a number of social skills resources. One of the things that we really believe in are assisting people with social skills, because it does help being part of society so much better and so much more functional if people have the social skills to participate in the activities of society or in the community, etc. We do have some additional resources. Again, the ones I just mentioned are in our resource library, our online resource library there. We do have a Facebook page, and we daily put up a post about a variety of health issues for people with Down syndrome, and certainly invite you to take a look at that. And then you can also sign up for our email newsletter, which we send out every 2 to 4 weeks with a lot of information about physical and mental health issues, social skills issues, etc., for people with Down syndrome. So we're going to stop the presentation, and Dr. Frank is going to take a look at the chats, and we will try to answer some of your questions.
All right, so there are only a couple in there. I encourage you, if you have a question you want to ask us, to go ahead and type it in, and we will do our best to answer it. So Dr. Chicoine, one of the first questions is that we referenced that one attribute of the groove is being repetitive in watching movies and TV shows. Can this repetition over time lead to difficulties in differentiating between real life and the fantasy world observed in these movies or shows?
Yeah, so we certainly have seen that, where people with Down syndrome will get just so fascinated by a television show or a movie or a Hollywood actor or whatever, and then the line between reality and the fantasy world can get blurred at times. Certainly based on the cognitive skill level of many of the people that we see. There is a childlike quality to that, and so it isn't necessarily a terrible thing, as long as we can kind of keep them on track, if you will. And again, using the strategies Dr. Frank talked about can be very helpful. But certainly it does become blurred at times, even take on a psychotic like nature, and so again, sometimes it does become necessary to treat with medications to help people get back on track. Again, not as the sole treatment, but as an adjunct to those strategies that Dr. Frank talked about. So that might be a place where someone is obsessive compulsive disorder with some psychotic features, and perhaps using an antidepressant along with an antipsychotic may end up being beneficial, and then so that the person can respond better to the other techniques.
Thank you. There's another question. How do you differentiate repetitiveness, inflexibility, desire for routine that's part of the groove to autism? So what are the differences will you see in the groove versus autism?
So we start seeing people at age 12. So hopefully they've been diagnosed with, if they have autism, hopefully they've been diagnosed with autism before they get to us, although that's not always the case. But certainly with autism, it tends to be three components. One is, first off, it's onset in childhood. So that's one thing. The second, but the three components are certainly the repetitious behavior, which can certainly look like the groove. But then there's also the communication impairment, and then there's also the decreased social interaction. And so many people with Down syndrome that would not, they might have the groove, but they don't have those other two features. Now, some people will, if they develop obsessive compulsive disorder, they'll get so focused on what they're compelled to do that they start to become less social. But certainly, to develop that, at 25 or 30, as part of obsessive compulsive disorder, would clearly be different than somebody that's had this since they were 2 or 3 years old, and then been diagnosed with autism. So you certainly would not expect the onset of autism at age 30 or 35. That would not be a typical thing.
Thank you. So there's two different questions that have to do about sensory. So like I said, I like to start with proprioceptive input because it's one of the easiest to incorporate throughout the day. Also, our proprioceptive system is the first one that we kind of establish or develop as children. And it's the first one we lose. And like I said before, it's about our body awareness. So if we know where our body is in space, we're going to be more alert and in tune and open to change. So when joint compression may not work, we can do any kind of activity that uses our muscles and joints. So exercise is a great way, whether it's riding a bike, going for a walk, going swimming. It can be a stationary bike. It doesn't have to be, a two-wheeler. You can do chores. So wiping down counters, sweeping, vacuuming, carrying the laundry, taking out the trash, making the bed. All of those activities are natural sensory input. We can also use things like weighted objects. So weighted blankets are really, really popular, and they do serve can be beneficial. One thing that often happens though is that the weight is too much or too light. So if it's too much, they're not going to like it. And if it's too light, they're not going to like it. But what the recommended weight is 7 to 10% of someone's body weight. No more, but it can be less if that seems to work best. And oftentimes, if you go to buy commercial products or look online for weighted blankets, their weight recommendations are like 14 to 26% of someone's body weight. So I really encourage you to not necessarily follow the weight recommendations that are on the box if you buy a commercial product. I also don't encourage sleeping under them, but like I said, weighted products definitely have a place. Vibration is also really great. Again, not everyone's going to like it. And so you really need to do trial and error. And when I talk about using sensory strategies, I like to talk about having a toolbox. So just like you might have a bunch of flathead and Phillips screwdrivers, I guess you would use those in Canada. I don't know if you have different names for your screwdrivers, but we have flathead and Phillips screwdrivers here in the United States. And we have different sizes for all of them because you never know what you're going to need. It's the same with sensory. What they like one day, they might not like the next. And so you need to be able to pull the next thing out of your toolbox to see if they like it. It's also important. I hear a lot that they try things here with me in the clinic and they love it. The family gets the exact same thing at home. And again, because it's home and not here, they won't use it because of that generalization of skills. It's not part of their routine at home. It is only part of their routine at therapy with Katie. And so working on that too can be challenging. But in the sensory resources on our website, it does give a variety of activities for all ages. So whether it's, rolling around in a blanket, kind of like making it like a burrito, or squeezing between pillows, or wrestling, shoveling snow, cutting the grass, whatever it might be. Like I said, any kind of pushing or pulling activity is really great proprioceptive input. But there's also vestibular input. So maybe they really like to swing. So you'd want to do something that's swinging forward and backward, not so much spinning, because spinning is going to really get them excited, but that forward backward motion is going to help calm their body in order to prepare for change. So I hope that addressed some of the sensory questions. Dr. Chicoine, this is another question for you. The risk for early onset dementia is higher for people with Down syndrome. How can the groove or even OCD impact this, or vice versa, not have an impact on it, I suppose?
I'm not aware that having the groove or not having the groove, or having OCD or not having OCD, necessarily puts you more at risk for developing Alzheimer's disease. What we do see, however, is some of our older folks who are developing Alzheimer's disease have a change in the groove. And sometimes that's actually one of the early signs. So the person may become significantly, have more significant grooves, and even develop obsessive compulsive disorder, where in the past the groove was much more controlled. Or they may really begin to lose the groove, where they, that's such a change for them, where they've done things pretty consistently and repetitiously in the past, and now they no longer have that skill. That can be a kind of a sign that the person is beginning to deteriorate with Alzheimer's disease. So more as a symptom, a change in the groove, more as a symptom rather than a cause that I'm aware of at this point.
Thank you. So those are all the questions that I saw in the chat box. If anyone has something that they're typing in now, we can give you a few more minutes, but I don't know if Laura, you'd like to chime in at all?
Thank you. Thank you again, both, for some very useful practical tips, takeaway, and explanations. If there are questions that people think of afterwards, perhaps if they forward them to us, you might kindly prepare an answer for them. I see there is another question in the box.
Yes, so it's about a repetitive question about the weather. Is it drizzle? When will it be sunny again? We see a lot of, I would say, obsession with the weather. And so this family understands that it's about anxiety about the bad weather, but the questions don't stop. So they've considered giving him a set number of index card, and each one would be for one weather question. And when the cards are gone, his weather questions for that day would need to be done. Is that reasonable? And I would say yes, right? So you're setting expectations and setting limits at the same time, but you need to let him know that, you only have 8 questions today, and then remind him after he's used 4 of them, you only have a few left, so you might want to hold off on asking that question. And then you're helping, again, set those expectations. And then maybe if there's something you want, a preferred activity you want him to do, he can earn weather question cards. And so then you're also getting him to do something that you want him to do, and then he's getting these question cards as a reward. But I do think that's reasonable. Dr. Chicoine, do you have any suggestions?
Yeah, I would just say, Dr. McGuire, our former social worker, called them weather watchers, and we have a whole lot of them in our practice. It's a very common thing. The other thing, sometimes, it's really not a problem, other than it's sort of a bother to the person that's being asked 50 times. And so directing the person to be able to check the weather themselves might be, an app on a phone or an iPad or whatever. So you direct them, instead of answering the question, you direct them back to that source resource, and they can look it up themselves. And so ultimately, hopefully, they will just do that without having to ask you in the first place.
Some feedback right there. That's great. Yeah, I hadn't considered the term weather watcher, but I can attest I live with one.
I would definitely say it's not universal, as there really is almost nothing that's universal in people with Down syndrome, but that's a pretty common.
Oh, that's great. That's great. Thank you so much for these practical suggestions. I think that's really useful. So we know that you have a busy schedule. You make lots of presentations. You take the time to partner with various Down syndrome groups in the US and Canada and around the world. And again, we thank you on behalf of the CDSS for taking the time this evening to prepare the presentation and deliver useful information, and most importantly, practical tips with a sense of humor, and also a reminder that sometimes some of these grooves are not so bad. It's something to be mindful of as we move forward. We also know that we have, as part of our audience this evening, other service providers, international service providers, who can use the takeaways that you offer and the resources that you share on your website. But the Adult Down Syndrome Center can be very useful. And again, I thank you on behalf of the Down syndrome community for the work you've done, the work you continue to do, and the legacy of work that you've prepared that is available for people to log into. So thank you very much again. Good night, everybody. We look forward to having you join us tomorrow night to listen to Dr. Jonathan Weiss about flourishing with an intellectual disability. And just in closing, Dr. Frank, Dr. Chicoine, any parting words?
I would just add, take a look at the resource library, and if there's lots of information. I think there's over 400 separate pieces of information. There now, written pieces and videos, et cetera. And if there's something that's not there that doesn't answer your questions, we do have a page on there where you can actually submit a question as well. So feel welcome to use our resource library as something that you can use in your daily life.
And I also want to say that you are not alone, right? So many of the scenarios we gave today are because we hear about them from many, many families. So know that you're not the only one going through it. And hopefully you learn something because we get to hear it every day also. And so we want to thank you for your experiences so that we can help educate everyone and know that you are not alone.
Thank you. Again, thank you, Dr. Chicoine. Thank you, Dr. Frank. We look forward to hearing from you again in the future.
Thanks so much for inviting us.
Thank you.
Good night.
Good night, everybody. Thank you.